Hey there, fifth-year med students. Welcome back to The Explainer. Today, we're jumping right into a high-yield tutoring session, specifically built around Professor Gita's lecture on GI pharmacology. We're going to break down gastric secretions, protective factors, and exactly how the drugs we use limit hydrochloric acid production. So, whether you're cramming for the boards or just prepping for your clinical rotations, this explainer is designed to get you completely dialed in on gut pharmacology. Let's get started.
Okay, let's dive right into this blueprint. Today we're covering 1. Physiology and protection, 2. Proton pump inhibitors, 3. H2 antagonists, 4. Antacids and protectants, 5. Choosing therapy, and we'll wrap up with 6. A high-yield exam review.
Starting off with Section 1, Physiology and Gastric Protection. Because, before we can even touch the pathology or the pharmacology, we have to grasp the baseline normal function.
Picture a constant, microscopic tug-of-war happening inside the stomach. On one side, you've got your protective factors. This is mainly the mucosal barrier made of mucus and bicarbonate, and it's heavily stimulated by prostaglandins, specifically PGE2. On the other side, you've got the aggressive factors. Hydrochloric acid is obviously aggressive by nature, but the real trouble kicks in with pathological imbalances. Peptic ulcers are essentially just localized mucosal disruptions where the aggressive factors totally overwhelm the protective ones. And clinically, this classically happens in 2 ways. First, infection by the gram-negative bacterium H. pylori, which just dumps cytotoxic factors into the mix. And second, chronic NSAID use. NSAIDs inhibit COX-1, which severely cuts down that absolutely crucial PGE2 production.
Now, all of this acid production really boils down to one main cellular machine, the proton pump, or the H plus K plus ATPase. This little guy sits in the parietal cells, pumping intracellular potassium in and luminal hydrogen out into the stomach. It's positively regulated, meaning it gets cranked up by cholinergic, gastrin, and histamine pathways via muscarinic, CCK2, and H2 receptors. On the flip side, PG2 acts as the brakes, negatively regulating it to dampen acid production. So here's the golden rule for this lecture. If we inhibit this pump directly, we stop acid secretion completely. But if we only block the upstream pathways, like hitting the H2 receptors, we only get a partial reduction. Keep that in mind.
Moving right along to Section 2, proton pump inhibitors, or PPIs. Let's talk about the heavy hitters that shut that pump down directly.
Professor Gita was absolutely clear on this clinical pearl. PPIs, we're talking about drugs like pantoprazole and omeprazole, are highly effective first-line options. But here's the catch. They're actually prodrugs. They absolutely must be taken in the morning on an empty stomach. Why? Because they literally require a highly acidic environment to activate into their working form, which is a cyclic sulfonamide. Once they activate, they bind irreversibly to the pump. Because of this whole activation process, you can't just pop them on demand after a heavy meal. They need consistent use over 4 to 8 weeks to properly treat things like GERD, ulcers, or Zollinger-Ellison syndrome.
But they aren't without their downsides, right? Pay very close attention to these drug interactions because they're absolute board exam favorites. First off, by artificially lowering stomach acid, PPIs naturally decrease the absorption of other drugs that rely on an acidic pH to be absorbed. Things like the antibiotic ketoconazole, ampicillin, and iron salts. Second, and this is the really dangerous part, they inhibit cytochrome P450 enzymes. PPIs broadly inhibit CYP3A3, which can decrease warfarin metabolism. That leads to a much higher risk of hemorrhage. Also, omeprazole specifically inhibits CYP2C9 and 2C19, which messes with the clearance of drugs like diazepam and phenytoin. Seriously, you have to know these for the wards.
All right, Section 3, H2 receptor antagonists. Let's step one level up the physiological chain.
Unlike our PPIs, drugs like famotidine and ranitidine don't hit the pump. They block the upstream histamine pathway. Remembering our physiology from a minute ago, this means they only give us a partial reduction in acid. Now, they are still super effective at reducing basal and postprandial acidity, and you'll frequently see them combined with basic antacids for a really potent 1-2 punch against post-meal heartburn. But you have to warn your patients, if they just abruptly stop taking them, it can trigger a nasty rebound hypersecretion of gastric acid.
Let's look at the specifics and safety for H2 blockers. They can cause some general GI upset, asthenia, and muscle pain. But the major flashing red exam flag here is cimetidine. Just like the PPIs we talked about, cimetidine inhibits cytochrome enzymes. You absolutely want to avoid co-administering it with certain antidepressants to prevent toxic buildups.
Oh, and a quick historical aside, you're not going to see ranitidine prescribed anymore. It was actually pulled from the market. Not because the drug itself was inherently bad, but due to a manufacturing contaminant called NDMA, which is a potential carcinogen.
Next up is Section 4, Antacids and Mucosal Protectants. What happens when we skip the receptors entirely? Well, antacids are just pure chemistry. They don't bind to any receptors. They simply directly neutralize the hydrochloric acid in the stomach to form salt and water, giving you relief in literally minutes. But they have side effects directly tied to their chemical components. Magnesium hydroxide causes diarrhea. Aluminum hydroxide, on the other hand, causes constipation. To balance this out, pharmaceutical companies usually just combine the two into one liquid or pill. It's a neat trick, but here is your critical clinical warning. Antacids cause chelation. If your patient takes an antacid containing aluminum or magnesium at the same time as the antibiotic tetracycline, they form this insoluble complex in the gut. It completely blocks the absorption of the tetracycline.
Beyond your basic antacids, we have other mucosal protectants. Bismuth and sucralfate act independently of receptors to just ramp up bicarbonate and mucus production, massively reinforcing that mucosal barrier we highlighted at the very beginning. Then we have misoprostol. This is a synthetic PGE1 analog. It activates EP3 receptors right on the parietal cells to negatively regulate the proton pump. Sounds great, right? The massive catch is that misoprostol and bismuth actually require dosing 3 to 4 times a day. As you can imagine, patient compliance with that schedule is basically a nightmare. Also, a very quick note on anticholinergics like atropine. They're essentially obsolete for this nowadays because they completely lack selectivity for the M3 and M1 receptors, which just leads to terrible systemic side effects.
On to Section 5, Choosing Therapy for Gastric Acidity. Let's put this into practice and make some clinical decisions.
And this brilliantly illustrates our clinical decision matrix. It's actually quite simple. If your patient needs complete acid cessation for the long-term healing of GERD or ulcers, you choose a PPI. If they just need to manage some background basal or postprandial acidity, an H2 blocker gives you a great partial reduction. But if they just ate a massive spicy meal and need relief in 5 minutes, you reach for an antacid. You get fast onset, but very short duration. It's all about perfectly matching the drug's mechanism to the patient's immediate clinical need.
Now, when it comes to an H. pylori infection, the stakes are way higher. Eradication is absolutely mandatory here, even if the patient is totally asymptomatic, because we have to prevent peptic ulcers and eventual gastric cancer. First-line therapy is a 14-day triple regimen. You use a PPI alongside 2 antibiotics, amoxicillin and clarithromycin. After those 14 days, you drop the antibiotics, but keep them on PPI monotherapy for another 4 to 6 weeks to ensure the mucosa heals. And finally, you must test to confirm eradication. You can't just assume it worked, because one round frequently doesn't.
So what happens if that first-line therapy actually fails? Well, we pivot to the backup plan, second-line therapy. You keep the PPI, but you switch out the antibiotics for metronidazole and tetracycline. And this is exactly where bismuth shines. You add bismuth specifically for its powerful, non-receptor-mediated cytoprotective effects. It helps soothe and heal that inflamed stomach lining, while the new antibiotics go to work clearing the stubborn infection.
Finally, Section 6, High-Yield Exam Review. We are at the finish line, so let's shift gears into a rapid-fire flashcard drill. Keep this straight for the boards.
Let's rapidly review these first 6 facts connecting the physiology directly to the pharmacology. Number 1. Chronic NSAIDs cause ulcers by inhibiting COX-1, which directly reduces your protective PGE2. Number 2. PGE2 normally protects you by negatively regulating the proton pump. Number 3. PPIs directly bind that pump, causing a complete cessation of acid. 4. Remember, PPIs are prodrugs. They absolutely require a low pH to activate, hence the morning empty stomach dosing. 5. Omeprazole specifically inhibits CYP2C9 and 2C19, so watch out for phenytoin and diazepam toxicity. And 6. PPIs broadly inhibit CYP3A3, which dramatically increases the risk of hemorrhage if your patient is on warfarin. Let's finish up the drill. Fact 7. H2 blockers only block one single upstream pathway, so you only get a partial acid reduction. 8. Cimetidine is the specific H2 blocker to watch for CYP inhibition, especially mixed with antidepressants. 9. Magnesium antacids equal diarrhea, and aluminum antacids equal constipation. 10. Antacids will chemically chelate and totally block the absorption of tetracycline. 11. Bismuth and sucralfate act independently of any receptors to boost your mucus and bicarb. And finally, 12, misoprostol is a fantastic PGE1 analog, but patient compliance is usually terrible because it requires 4 daily doses.
So we've covered a ton of ground today on acid suppression. But before we go, Professor Gita's lecture ends on this really fascinating, forward-looking note regarding probiotics. By modulating the gut microbiota, we are learning that we can do far more than just treat simple diarrhea or constipation. There are ongoing trials right now investigating how these live bacteria impact the gut-brain axis, potentially treating behavioral dysfunctions in autistic children and a whole host of other neurological conditions. It leaves us with a pretty profound question. As we master the pharmacology of the stomach, are we actually unlocking a pharmacological backdoor directly to the brain? Definitely something to think about as you study tonight. Thanks for joining me on The Explainer, and I'll see you in the next one.